Hello everyone, welcome to module 7 which is on the condylar fracture. So condylar fracture is most common and often overlooked in clinical examination. It can be either unilateral or bilateral, that is either on single side or on the both side. It can be either intracapsular or extracapsular fracture. Intracapsular fracture is till the condylar head and extracapsular fracture is till the condylar neck. It can be either displaced, undisplaced, which we can see in the picture, or dislocated. Clinical features: pain and swelling over the preauricular region, ecchymosis over the mastoid region, which is the battle sign, CSF oturia due to break in the tegmen bone, hollowness over the condylar region, restricted incisal opening, and locked mandible. Then features of unilateral condylar fracture. There is a premature occlusion on the ipsilateral side, open bite due to loss of vertical height on the contralateral side. This affected side deviate on opening and is common because of the interruption of the action of the lateral pterygoid muscle. Limited lateral tissue movement away from the fractured site but may be maintained over the fracture. Then bilateral condylar fracture features. There is a bilateral loss of vertical height which results in anterior open bite with posterior gagging. Restricted mouth opening may be associated with other fractures. Radiographic assessment, we advise Townes view, epimandibular coronal position view, Panorex, which is OPG, CT scan, or MRI. Management, the treatment goals are that there should be no pain and minimum interincisal distance of 40 mm on opening the mouth. On excursions, movements are good. We should restore the pre-injury occlusion and good stable temporomandibular joints, and there should be a good symmetry of face and the jaw. Then we have indication for open reduction by Zaid and Katz. The absolute indication for open reduction are condyle displaced into the middle cranial fossa, not possible to obtain adequate occlusion by closed reduction, lateral capsular displacement of condyle, and presence of foreign body. The relative indications are bilateral condylar fracture in an edentulous patient without splint, comminuted midface fracture, prognathic or retrognathic jaws having associated bilateral condylar fractures, generalized periodontal conditions which are poor, jaws which are totally or partially edentulous, and unilateral condylar fracture with lack of base. Then by Fonseca, we have absolute indication which we have already seen is condyle displaced into middle cranial fossa as the glenoid fossa is very thin. Then there can be presence of foreign body in extracapsular displacement of condyle laterally, malocclusion not amenable to closed reduction. Strong evidence for open reduction are bilaterally fractured condyle displaced grossly above 45 degree, or there is any anatomic reduction of ramal height about 2 or more than 2 mm. Condyle fracture with an unstable base, unstable occlusion generally seen in periodontal disease, less than 3 teeth per quadrant. Condylar fracture for which adequate physiotherapy is impossible. When to treat with closed reduction? When there is non-displaced or incomplete fractures, or the fracture is isolated intracapsularly. Condylar fracture in children, except in the case of absolute indications, medical illness or injury that inhibits ability to receive extended general anesthesia. Use of IMF and elastic traction for conservative management of condylar fracture. First in this we will apply the arch bar. Then we will guide the teeth into occlusion manually. After guiding the teeth, if occlusion attained, then IMF is applied and it is maintained. After that, functional therapy is given to the patient. If occlusion is not attained, then we will apply elastic traction for few days, and then occlusion is attained, IMF is applied, and functional therapy is given. Treatment factors that should be taken into consideration are location of the fracture, amount of the vertical reduction in height of the ramus, which is around about 2 mm, degree of angulation, around 45 degree, relation of condylar head to the glenoid fossa, fragmentation pattern that is simple versus complex, association with other medical injuries, dental occlusion or status of dentition, association with other facial injuries, with systemic injuries, and with the condition of patients, and then comorbidity factors, foreign body, temporomandibular joints. Close reduction. Advantages are relatively safe procedure, No injury to vital structures. Hospitalization may not be required. Long period of intermaxillary fixation is a disadvantage. Growth disturbance can occur in children. Success depends on patient's cooperation. Long-term follow is needed. Contraindicated in medically compromised patient, and it is a challenge in partially or totally dangerous patients. Then we have open reduction in fixation. Advantages are anatomic reduction of fractures, short or no intermaxillary fixation, and early function. What can be a disadvantage? It is the complications such as a scar, and there can be injuries to neurovascular structures. Infections, hospitalization is required, high cost of treatment, and there should be steep learning curve for surgery. There are various incisions based on location. Like we have diapapticular fracture. In this, we will give preauricular or retroauricular incision. Neck fracture. In this, we will give intraoral, periangular, retromolar, preauricular, or postauricular incision. For base fracture, there can be intraoral, periangular, and retromolar incision. Then there is comparison of different fixation method. So there is single plate. The advantage of single plate is it is easy to adapt and fix as placed along the long axis of the condyle. The disadvantages can be that it does not neutralize the forces acting on the fracture ends. It is relatively heavier plate needed. In case of two plates, it neutralizes the tension and stress along the fracture. It is easy to triangulate, aids in reduction of fracture, suitable with multiple fractured fragments. The disadvantage can be it is difficult to fix two plates in the narrow neck of condyle. Then in case of lambda plate, the advantages are single plate neutralizes the tension and stress as two lower limbs follow the anterior and posterior border of the condyle. It is suitable in narrow neck of the condyle. The disadvantages can be wider exposure is required, junction of two lower and upper limb area of weakness prone for fracture, difficult to adapt as the stock plates may not be suited for all types of fracture. In case of delta plate, it is a single 3D plate which neutralizes the tension and stress as two vertical struts follow the anterior and posterior border of the condyle. Plates don't have an area of weakness. Their disadvantages are it requires a wider exposure, difficult to adapt, and at times upper horizontal strut may be wider than the bone available. Conclusion: the management of condylar fracture is a controversial topic with different opinions regarding closed and open methods. The decision to treat the patient in either way is the surgeon's choice or depending on the case. The case, however, is not complete till the patient has stable occlusion and function. Therefore, regardless of method of treatment, active physiotherapy must be encouraged. Thank you.